Shankar. I'm one of the general pediatricians here with ETSU Pediatrics, and we are very, very fortunate to have our speakers today, Dr. David Wood, who needs really no introduction to us. He is our chairman of the Department of Pediatrics, along with Dr. Kiana Johnson. I just want to go over a couple of housekeeping items, and we'll introduce Dr. Wood, followed by Dr. Johnson's introduction. I want to remind everybody to please sign in using the CME ID number that's located on the desk in the back. You need to call the CME number and sign in using the event ID. Even if you are a medical student or resident who doesn't really need CME credit, please use that line and sign in, because that's how we count our numbers for CME and are able to continue the series. I also want to remind everyone at the end of the session, please, please, please complete your evaluation forms, because again, that's required for us to be able to continue the series. Like I said, it's my great privilege to introduce Dr. David Wood to you all. He has been with us in the department since 2014, and prior to coming here, he came to us from the University of Florida, Jacksonville, where he was not only the director of the Global Health Education Program there, but also the medical director for the Health Equity Research Foundation, as well as was the statewide medical consultant for the Office of Healthcare Transition. His experience and knowledge on the topic today, healthcare transition, is it a bridge or an abyss, is extreme, huge. He ran the healthcare transition clinic there in the University of Florida for 10 years prior to coming here. And at its time of initiation, it was really one of 5 in the country, and was sort of the leader in this field, following which now there are hundreds of transition care clinics around the country. So I'm excited to learn from him and Dr. Johnson today, and let me pass the microphone on to Dr. Dodd, who is going to introduce Kiana Johnson for us.
So it's my pleasure to introduce Dr. Kiana Johnson, who's going to be the co-presenter today. Dr. Johnson has received the trifecta of degrees from Purdue University, with her bachelor's, master's, and PhD. She's done not 1 but 2 postdoctoral programs in adolescent health and youth with special healthcare needs. And she also has an MPH from the University of Minnesota. Her areas of research include healthcare utilization, as well as transitions of care. So this is definitely her specialty. So I guess Dr. Wood is going to start off.
Thank you. Okay. So Brian, if we get on the wrong mic, you will tell me. I'm going to put it right here. Can people hear okay? It's a pleasure to be here. Kind of a depressing room, but it's okay. We'll do it. We'll do it. We're going to talk about healthcare transition. We don't have any financial disclosures or conflicts of interest. We wish we did, but we don't. So and what we want to do is go over kind of why healthcare transition is important, why it's become even more important in the last 20 years or so. We want to go over with you the individual level, and we're going to really focus more on individual youth factors that affect transition, success, or failure. But we'll also allude to systems issues, and we'll probably cover that at a later time, because those related to insurance and health systems issues are very complicated. But we also want to spend some time going over how we want to develop a transition program here in our clinic, and we're going to go over kind of how that's going to be laid out for you in this presentation.
All right, so adolescence, it's a stressful period during development, and it involves transitioning from childhood dependency to adulthood independence and self-sufficiency. Depending on, right now, so adolescence includes individuals between 12 and 24, but that also includes emerging adulthood, which is a new line of research that people are engaging in. So during adolescence, youth are going through many different transitions. So healthcare is one of those many transitions. So in education, so some are going into high school, some are graduating high school, as well as employment, whether it be part-time jobs and after graduating high school, going into the full-time employment workforce, independent living or living outside of the parents' or the guardian's home, the guardian's place of dwelling. Could also be another transition that youth are in the process of doing in healthy, the last is healthy, happy, productive adult lives. So, and that includes relationships, be it work, friendships, peer relationships, and navigating how those change as they become independent and self-sufficient individuals.
Perfect, good. Excellent. So whenever we give this talk, or whenever I give this talk, and Kiana and I are doing this together for the first time, we look out at the audience, and I have to say that many in the room are going through these stages of transition right now. So you're changing places where you live, you're changing jobs, you're changing your training programs, you're going through, sometimes some of the people are going through relationship changes. Some are going through major life events like having a baby, like Katie did this past week. So lots and lots of changes going on. And in the midst of that, we're trying to manage chronic disease and help them be healthy and be able to take care of their chronic disease. One way to describe transition is in 3 phases. We'll talk a lot about the first phase, which is preparation. And then there's transfer, and then there's successful transition or engagement into the adult healthcare system. We're talking here mostly about healthcare transition, but as Kiana described, the transition is really across lots of life issues, and we try, as we help youth transition with regard to their health care, take into consideration their other life issues. But preparation includes taking increased responsibility for the management of their own health and health care, understanding and planning for changes, because there are lots of changes that happen, and we'll go over those at 18, 19, 21, and really preparing to plug into adult care. The culture between adult care and pediatric care is quite different. In pediatrics, we're very family-centered, nurturing, if you will, and really work in collaboration oftentimes. If a child's health care is suffering or their health is suffering, we may even step in and report the parent and the family to protective services because we have a legal obligation. Once they become an adult, they're really responsible for themselves. And oftentimes in the adult healthcare system, you see that you're responsible to follow up on things, and if you don't, that's your tough luck. So there's a major cultural shift that we have to prepare them for so they can be independent in a much more, in a setting where they really expect independence. There's many children with chronic disease in this country, and for teenagers it's almost 20%. So there's close to 750,000 youth who are in the process of transitioning with fairly significant diseases, and we'll go over those, because of different changes in health care and life expectancy. We'll go over that a little bit. There have been a lot of different national organizations weighing in on this issue, and we'll go over that a little bit too. So it's become, over the last 30 years, it's become a much bigger issue, realizing that we have a very poor handoff between pediatric and adult care, and we need to do a better job. Part of the, if you can read this, part of this is that we've been incredibly successful at treating conditions of childhood, genetic conditions, other conditions that arise out of, say, prematurity or congenital heart disease, these sorts of things. Back 40 years ago, these conditions really didn't, the people with these conditions didn't survive to adulthood. They died in their, before teenage years usually. But now muscular dystrophy, cystic fibrosis, sickle cell disease, congenital heart disease, the life expectancy for these diseases now in the 40s, 50s, 60s. Down syndrome, Back in the 60s, the life expectancy was 8 years. Now it's 60. So there are more adults with congenital heart disease than children with congenital. Over 1 million adults have congenital heart disease. So there are more adults with cerebral palsy than children. But part of the problem is we have not built an adult healthcare system to receive them. And that's part of the big challenge, which we're not going to talk that much about today because it's involved. But part of the deal is that, you know, children with chronic, you name the disease, chronic renal disease, they're living so much longer, and the adult system really hasn't caught up to take care of them. Although, as Dr. Jaishankar mentioned, with the with the proliferation of transition clinics, expansion of med-peds programs, with a real emphasis on handoffs, more and more adult providers are being trained to take care of conditions arising in childhood. And so this is a little cartoon. It says, it's pretty small up there, first they make you button your shirt, then they make you tie your own shoes. You got to ask yourself, where is this all heading? And that's really what we do in transition. We try and encourage the youth to take increasing responsibility until they're ready to be independent.
Do the next one.
I do the next one?
Next two.
Okay. So there's a lot of factors that influence the success or failure of transition. Some of them are social trends. We'll go over those. Youth development is a major issue. We'll talk a lot about that. Some of the things we won't talk about today, just for lack of time, is health insurance, which has improved under the Affordable Care Act with parental insurance being able to cover up to 26. It used to be you had to be completely disabled to qualify for your parents' health insurance. And there's other health insurance things that have happened that have been very positive. It used to be that this age group, it still may be, this young adults, 18 to 24, had the highest uninsurance rate of all adulthood. And that's changing. And we've already alluded to this, availability of adult providers. We won't talk about that. We're going to talk a lot about what our role is as pediatricians. So one of the major secular trends that's happened over the last 60 years, if you went back to the 40s, only about 14% of high school graduates went on to post-high school education. Most people went to work in the factory. They started a family in their late teens, and they really basically stayed in that position, and you could support a family with a factory job in those days. Those jobs are, a large percentage of those jobs are gone. My grandfather went to work in the coal mines, and he supported a family by doing that. There used to be about 200,000 coal mining jobs in this region. There are now 20,000. So, and that's true of all manufacturing. But what's also happened is there's been this secular trend of increasing percentage of people going on to post-high school education. So now it's about 60% will go on to community college, a four-year college. Unfortunately, only about half of those finish a four-year degree by the time they're mid to late 20s. And there's really a mixed path now. People are going to school, taking time off to work. There's really a very varied path to going through this period. Actually, it's called emerging adulthood because of all the changes going on. Another major secular trend is marriage, age of marriage. It used to be, again, like I said, around 20, and now it's late 20s, the average age of marriage. And many people are choosing other paths of cohabitation is much more common prior to marriage. And so the bottom line of this is the pathway to adulthood is really changed a lot. It's becoming quite varied. It's prolonged. It used to be very abrupt. You finished high school, you were an adult, and you had to support your family. Now it's going on for 10 or 12 years, and it's during this very time that we're trying to continuing to work with youth to help them, if they have a serious chronic disease, to help them make sure they focus on their health and health care.
Right. So in adolescence, youth are generally trying to figure out three main things: what I am, who I am, and how do I fit in. And so this is about identity and culture and just the social surroundings. Thank you. So within the first being who I am, it pertains to puberty, so physical development as well as cognitive development. And within cognitive development, so adolescence, we have the early, middle, and late phases of adolescence, but also looking at Piaget's cognitive development stages, we see how he looks at formal operational thought. So for early, being 11 to 13, you see more concrete thought and no future perspective. So adolescents, generally in this age range, don't really look at how their actions now influence what they're going to do in the future. And then so for the middle, they now have more abstract, they can develop abstract thought, as well as a better future perspective, but it's not always used. So although they might know that something can happen in the future, it doesn't necessarily get applied to them. And then we have late adolescence, which 17 to 21, and so they have this established abstract thought and then a future orientation. So they have their future selves. So, and how their actions can influence what they want to do and how those can be, different things can be positive and negative consequences of something that is occurring now.
It's really interesting in the clinical encounter to kind of try and put an adolescent into these different stages. If you're, say, talking to a young woman who's sexually active, not using contraception, and you ask her about, well, what do you think could happen? And she'd say, well, I'm not going to get pregnant. I go, okay, you're having sex, you're not protecting yourself from getting pregnant. Why do you think you can't get pregnant? She said, it just won't happen to me. So she's pretty much concrete, has chosen to believe that, and really can't appreciate the consequences of future consequences of those actions. And so a lot of times when we're working with adolescents, you have to really, if you're trying to motivate them to, say, be more involved in their health care or health management, and they're concrete, you want to pick things that are very proximate, very close, immediate, that they can understand, as opposed to long-term, motivating them with, say, longer-term goals. When they get into abstract thought, you can be talking about, say, if they're smoking, you want to talk about quitting smoking. You could be talking about their future goals in life, their desire to run a marathon or do something athletic. They could then have those longer-term goals. They could probably relate to better, and they'll be motivated by those. Whereas if they're early adolescent, will not, more than likely, not be motivated. This is quite fluid, though. I will say the ages are not fixed at all. There are some people who get into adulthood and are still in concrete early adolescent development. So part of this has to do with adolescent brain development, which has been a huge, along with early brain development, this has been a very subject of much research in the last few years. And this is a cartoon of the brain. And this is kind of the primitive brain. Where's my pointer here? The primitive brain here, which includes the amygdala, hypothalamus, thalamus. And this is really the seat of emotions. This is the seat of the fight and flight reaction. This is the primitive brain. This is where we learn to fight back or flee if we're in danger. And the prefrontal cortex, this develops very early in the concrete thought and in even early childhood. But the prefrontal cortex develops late. And that's this graph here. The subcortical regions of the more primitive brain develop early, but the prefrontal cortex develops later, so you have this gap. And this gap is the subject of a lot of interesting research. It has a lot to do with the behavior of adolescents in terms of their motivation to do things, why they do things. There's a term called hot cognition, where given some choices like, say, getting in a car with friends who have obviously been drinking, do you risk being rejected by your friends versus taking the risk of getting in the car, even though you know it's not the right thing to do? The amygdala takes over, and you've got to do what your friends want you to do. You basically shut off your prefrontal cortex, which really is the rational brain, and telling you to be concerned about those risks. And so that's oftentimes the kind of the period of adolescence into young adulthood. They estimate now that this prefrontal cortex is developing up to about 29 or 30 years of age. So there's a lot of development still going on. So this has very significant implications for how we work with adolescents, how we work with them on high-risk behaviors, but also how we work with them on taking care of themselves with regard to their health and health care. We have learned that adolescents really don't believe that they're invulnerable. and they may even, if you ask them about it, like what's the risk of getting HIV from unprotected sex, they may acknowledge those risks. But they have this lack of future orientation, they discount the future risk, and they have this kind of, the social development of wanting to fit in, being more influenced by peers, and a really intense drive from that amygdala for immediate benefit. So they become much more impulsive in their actions, even though they really do recognize the risk. So talking about it sometimes is not as effective as kind of working through the situations, asking them what they do in certain different situations, and helping them think through those situations before they're in the midst of them and they really feel this tremendous drive to do some things that they may otherwise regret later.
There's also some new research in terms of the adolescent brain development that shows and supports that there can be delay in the prefrontal cortex in terms of that development for those who have been exposed and experienced trauma and abuse.
Good point. Yeah. And there's actually other research that reminds me that it's measured the size of the amygdala with response to trauma and abuse. And that's actually larger. So you have a larger, more active amygdala and a less developed prefrontal cortex, which really leads to a lot of impulsive, sometimes aggressive behaviors, which we can see in people who, even as they get into adolescence, who've been traumatized.
So, who am I addresses identity development. And so things that we have to take into context when we think of adolescents are, so race, sexual orientation, how do they identify as well for themselves? How do they identify with one particular sex or a different, or none? Religious and political affiliation, as well as vocation, or just their future orientation for their vocation as well. Emotional development. So we mentioned before that adolescence can be a stressful time, but also in terms of brain development and context, the roller coaster of emotions can come as a result of not knowing how to respond in XYZ situation. And it often leads to excitement and anxiety. And then also in adolescence, that's where you see the emergence of mental illness. Thank you. I like this slide. Don't laugh at a youth for his fictions. He's only trying on one face after another to find a face of his own. We can flip the slide and I'll go back to that. So when we think of adolescence and how identity and social environment and culture all fit in, it almost looks a little messy and complicated, but we see the things that really do influence adolescent behavior, shifting more from the parent to the peers. And we see, so peers are more influential over parents, and so that's why we generally encourage parents to have a really strong influence in the younger years while youth are still receptive to that. And then also with media, technology, and culture. So with media and technology, I also included Maslow's hierarchy of needs, and the bottom is internet, which now seems to be more of an influence on youth and youth behavior than it has been before. And in terms of culture and internet, it's a culture which is situated in a whole different culture. So even in terms of language, abbreviations, and like, I can't think of any abbreviations that adolescents might use.
LOL.
Okay, yeah, LOL. Or MCM, Man Crush Monday, TBT, Throwback Thursday. These are different things that are used within the realm of social media. And so how this fits in within the context of healthcare, so like the example of a patient who's on high-dose steroids that have an effect, but they also have an immediate negative consequence. Weight gain, stretch marks, acne, all these different things. And the idea of fitting in and wanting to be like everybody else supersedes the idea of being well, which, this is what people are surrounded with, adolescents on a daily basis, and yeah, it's tough.
I mean, I've had many patients who have, if they have some sort of condition that requires daily management, whether it's, insulin management for diabetes or bowel management if you have spina bifida, even though your disease might be quite apparent to your peers, like spina bifida would be, there still is a tremendous need to fit in and to not be different. And so, especially for our, cognitively normally developing teens, working with them to acknowledge their condition, acknowledge the kinds of things they need to do to take care of themselves on a day-to-day basis, even raising the issue of, is there anyone that you can confide in about the fact that you do take insulin or that you do have to take medicines every day. Even something as simple as asthma, even though it's fairly common, taking medicines is embarrassing. So we do work a little bit with that. We ask them about it, whether they feel comfortable sharing that with peers, and that's an incredibly important influence. And with the internet nowadays, I was in a youth forum last year about this time at University of Kentucky. We had about 60 youth talking about what was going on in their lives, and they said the major stressor in their life was social media, because the need to fit in was more intense. The need, hearing about, one girl stood up and talked about how she had followed and was close to someone she'd never met in California, and that girl committed suicide. And that was on the internet. And so you have this incredible spread of toxic kind of communication and the desperate need to fit in. So if you have a health problem, the last thing you want people to do is get on the internet and talk about the fact that you have, even if something innocuous as asthma. So we do work with them about that. We ask them to kind of think about disclosing that to a friend, and usually if they do end up disclosing it to one friend and they realize they're not rejected, and usually friends are very accommodating and sympathetic about it, then that makes it a lot easier to kind of go public with their condition. And I had one young woman with spina bifida. Actually, she didn't have spina bifida. She had basically a cord transection from transverse myelitis, but she was basically insensate from about T10 down, and she wanted to go out and party. She wanted to go out and do things that other kids did, and she didn't do the daily things she needed to do to take care of herself. And as a result, her health dramatically suffered. She got infected. She got, chronic renal disease from the infections. She got osteomyelitis. She had to have a hemipelvectomy because she had osteomyelitis. And even then, she refused to not, to take care of herself in a way that would cause her to be removed from her social peer group. And we really worked with her hard, but she was an extreme example of how youth will suffer quite a bit to fit in rather than to necessarily do the daily health maintenance that they need to do.
Are you all familiar with Maslow's hierarchy of needs?
Yeah.
All right.
So this is saying that internet is a more basic need
Than food and water.
Than food and water.
Yeah.
Okay. So how do we do healthcare transition? That'll be the second part of our talk. There's a number of frameworks that have been publicized or worked through, and not a whole lot of evidence base, but I'll share you the evidence base that there is. But when you think about transition and what's going on with a young person during adolescence and early adulthood, their medical care is changing, their insurance is changing, they're developing, hopefully, enhanced self-care abilities, and then they have all these other things going on that you want to support. Most people don't go to the doctor because they want to go to the doctor. They go to the doctor so they can be well and do the other things in life they want to do. So we actively ask about their goals in life, we support those goals, and we work with them to make sure that their health care or other things don't interfere with that, but in fact support that. So one of the good outcomes that we're looking for is access to continuous high-quality medical care through pediatrics into adult care, and we'll go over that, kind of how that process should work. And then we really want to maximize their quality of life, their life satisfaction, and their role attainment. In other words, their ability to go to school or to have relationships that are satisfying. I like this. This is from Great Britain. I like this because it shows that over time is on the bottom here, the role of the parent diminishes, the role of the youth increases, And as far as the service system, we should be connecting between the two. We should be supporting this change here, and then we should be connecting to adult services to really support this transition to adult services. I like to think of it that way. And we'll share with you that we do have a tool where we measure the youth's increasing ability to manage their own health and health care. So the AAP, AAFP, American College of Physicians, the internal medicine folks, and back in 2002 actually we published a paper, but then published a more updated clinical report in 2011, and actually a new one's going to be coming out pretty soon, where they laid out basically a guideline for transition. So the guideline starts at age 12, where you really start raising the issue. I ran a transition program. I would get referrals from pediatricians, specialty pediatricians, and more often than not, I heard that I said, how did you come to hear about our clinic, or how did you come to our clinic? And they would say, well, the last time I met with the endocrinologist, he said, well, this is your last visit with me. Here's a referral. And they were pretty shocked because there was no real preparation. So that's really a very common problem, and so we'll go over what the pediatrician can do, but there's kind of a staged approach to working through, kind of like the developmental stage of adolescence, to help them be ready for transition. And I will say this is true for all adolescents, whether they have a chronic disease or not. All adolescents need to know about their preventive health, about their sexual health and health care. So we need to be doing transition and expect them to become more independent regardless. And then one of the key things is this transition extends into their transfer to adult care. There you go. So there have been a number of studies looking at both what happens during transition years in specific diseases and how do we support that to be more successful. One of the main findings in transplant patients, patients with diabetes, patients with rheumatologic disease, some of these diseases that are pretty sensitive to being to their health care and adequacy of self-management, has shown that health care drops off in adolescents, they don't go to the doctor as much, and their health suffers. The rates of organ rejection go up from this age 16 to 24. Diabetes, hemoglobin A1Cs go up, indicating poor control. And so this is an area, this is an age when if you have a chronic disease that's pretty sensitive to daily management, daily medicines, then you can have a deterioration in your health and even die. Congenital heart disease is one they have studied, and without adequate preparation for transition, even those with very serious congenital heart disease oftentimes don't get connected to an adult. We now have adult congenital heart centers. But there are various ways you can support transition, and we'll go over the overall model, but there's been a number of studies looking at trying to make a contact, typically, and this has been in Great Britain, where they may have pediatric and adult providers in a specialty area have a joint clinic, so you meet the adult providers. That makes for a warmer handoff. And that's what I just, but also having contact with the adult providers to go over there and meet them before you're transferred. Care navigators are very effective, and they've been looked at predominantly in diabetes, but really help transition youth more successfully. More of an emphasis on education and skill building using particular evidence-based materials has been effective. Specialized healthcare transition clinics have been shown to be effective, but even some things like just building in prompts to your electronic medical record, which we plan to do to help raise this issue so that the youth and family can start to organize around it years in advance, shown to be helpful. They're doing a major study now at Texas Children's, where across all specialties and general peds, they're building in these prompts for everybody to be raising the issues of transition and doing transition education. There's a number now of clinics that are either specialty-based, and you can read these, and across a lot of different kinds of diseases, and a lot of within different diseases like cancer or congenital heart disease, They are trying to develop adult kind of programs so that they can hand these kids off to folks that are more comfortable taking care of diseases of childhood. And there have been primary care programs. This is the one that I helped start, and we is still running. It has about 1,000 youth involved now. That's a primary care-based program. It's difficult to do primary care-based programs in rural settings because of the geographic, it's so spread out. But in urban settings, primary care programs are pretty common.
Anything in Tennessee?
There is there any transition program in Tennessee? No, I don't think there is. I haven't heard one at Vanderbilt, and I don't think there's one in Memphis.
Not primary care.
Not a primary care.
Yeah, but they have subspecialty.
Yeah, some subspecialty like the heart and within congenital heart disease. The cardiologists have been actually, and the thoracic surgeons have been really progressive about this. 10 years ago, they started training. You can do a fellowship in adult congenital heart disease now. So there are now enough adult cardiologists trained in congenital heart disease to be able to hand off a lot of these folks in centers. But in many of the other areas, like cerebral palsy, there are really no adult equivalent services. When we did Jack's Hatch program, and we had about 200 people with, spastic quadriplegic cerebral palsy, many of whom were bedbound, had lots of spasticity problems. Those don't go away when you become an adult. They actually get worse. And so manage their baclofen pumps, managing them with baclofen injections and those sorts of things, there isn't the equivalent of a child PM&R. The adult PM&Rs don't do it, the neurologists don't do it, the neurosurgeons don't do it. So you really have to, we had to put together a team that included a neurosurgical nurse practitioner, a neurologist, who else was involved in that? But a number of folks that would manage the baclofen pumps, because lots of times some of these programs that we've developed in pediatrics just don't have an adult equivalent.
And Gillette Children's Hospital in Minnesota, it's not necessarily, they have the Lifetime Clinic, which I wouldn't necessarily call it a transition program or preparation, because it's the patients that go there are there till, they're there for a lifetime essentially. And most of their patient population are usually the muscular dystrophy, spina bifida, and cerebral palsy patients as well. And it's all, they have patients that are in their 60s and 70s that still go to that clinic.
But there have been some centers for, solid organ transplant, developing, a transition program within that to hand off. And oftentimes in those programs, there'll be a surgeon that can bridge those two programs from pediatric to adult care. So in some specialty areas, there are surgeons or other clinicians that can bridge. But oftentimes, when you hand off from pediatrics to adult, pediatricians stop seeing them and the adult providers have to take over. And there are a number of diseases where they're just, I was giving a talk in Miami about this once, and a geneticist said she was following 3,000 patients with neurofibromatosis, and up into their 50s and 60s. She's a pediatric geneticist. And she said she didn't have anybody in the community she could hand those patients off to. So genetic conditions are very commonly kind of orphaned when they go into the adult world. But there's a big movement to train and primary care as well as specialty care on this issue. It's an issue that's taken off in terms of the need because of the problems that youth are having during transition and increased morbidity and even mortality. There's a recognition that we need to do a better job of training the adult providers. This is what's called the 6 core elements. There's a national center funded by Maternal Child Health Bureau called Got Transition. And they talked to a lot of folks involved in the transition world to say, what are the stages that a clinic should go through to develop a transition program? And these are the stages. Should I go through these real quick? You can do it? Okay, go for it.
The first of which, so transition policies, so actually developing a policy. And we're going to go through each of these stages in a little bit more detail after the summary. So developing a policy and then also being able to track and monitor progress. So looking at having a systematic way to move data and information. And now that's most people are now using EMRs. Transition readiness, so just assessing the youth skill in terms of how they manage their health. and where they are and how to get them to where they need to be prior to being transferred to the adult provider, and then planning that actual process. So what is it that needs to be accomplished within said number of years so that that can happen effectively? And then transfer integration into adult-centered care, and that usually involves like contact with the adult providers, but then also a feedback loop as well. And then transition completion with ongoing care with the adult provider. So after established care and follow-up, that this transition has actually occurred.
You have to pick it up here.
Okay.
So this is an example of it's pretty wordy, but it's a transition policy. We don't have one for our clinic, so we're going to need to establish this pretty soon. All this really is saying is, you know, we need to prepare you to transition to adult care, and there's certain things we're going to do to help you with that. And one of them is to spend time alone during a visit. One of them is once you turn 18, we're going to treat you as an adult, and that has legal implications and information implications that are very complicated, and that we will transfer you eventually. Just saying that someday you're going to need to leave us is something that starts the discussion, and parents are obviously thinking about this, but as a clinic, we need to really make the policy, you know, post it so that families can see it, or maybe put it in the patient handbook, so they can really start asking us about, you know, what am I going to do with my child once they're 18, 19, or 20. This is kind of the outline of the different things that we talk about in terms of in this policy. We won't go over those because we're running out of time pretty quickly. There are these 6 core elements. We want to go over them very quickly. Transition tracking and monitoring. Really, initially this was thought of as identify your youth that have special needs, make a list, and make sure you're tracking them. Now we have an EMR that we can track everybody, and we can organize them by diagnosis, but we should be flagging people that have special needs where we want to have a special emphasis on transition, and where we can kind of document that they're making progress through this developmental stage, and we'll show you how we do that. The transition readiness is kind of the core activity that we do. We ask them, you know, do you know how to take care of your own health? And that might be something as simple as, you know, contraception, or knowing about your immunizations and when to get them, or it might be something as complex as daily insulin management. And do you know how to access health care? Can you make an appointment? Can you come talk to the doctors? Can you know how to, if you have problems with your insurance, do you know how to resolve them? Which is really hard. You know, can you get a prescription filled? Do you know how to get it refilled?
And not only do you know, but are you doing it?
Right. So what we developed was a transition readiness assessment questionnaire, it's called. It is one of the few transition assessments. It's kind of like a developmental assessment like we do in younger children, but this has to do with the tasks of becoming an adult. And we use the stages of change kind of framework to say, no, I don't know how to, and I'm not even thinking about it, to yes, I can do this all the time consistently, which is one of the 5 stages of change. And we ask about managing medicines, appointment keeping, tracking health issues, and talking with providers. We actually have a new version of this coming out that won't have this 5th domain, but right now we have this. We have the youth fill it out. They mark themselves, we score it, and we determine, are you kind of early in your ability to do these basic things, or are you late? And we're going to be tying. So when we talk to them, then we challenge them to think about what are the things you could do to start learning to manage your own medicine? What are the things you could do to manage your own appointment keeping and make an appointment? So there's we have what we call goal statements, and this is going to be built into the Chatez, the new Chatez, which we'll explain in a second. It'll be automated. But we basically have a list of things that they could do that we can, through kind of motivational interviewing, throw out there and say, would you be interested in bringing your list of medications next time? How about contacting your pharmacy on your own and trying to refill your prescription? Just do a dry run. You got your parent as a backup, and you can go do it. And if it doesn't work, then we'll kind of problem solve and process why. But there's lots of potential goals here. There's even a MyMed schedule automated text reminder on the internet that you can log in, put your medication schedule in there, and it will send you texts. I have found, we've used this a lot, and I have found that people do that for a few weeks and they turn it off because they get really irritated by the text. But it at least sets them up to understand that I need to prompt myself to take my medicines. One of my favorite questions is, so tell me about your medicines. And I look at the youth, and if the youth looks at his mother, instead of answering, I say, well, no, they're your medicines. Tell me about your medicines. And he can't. So I'll say, well, okay, that's something we could work on. So Mom, tell me about his medicines. You know, so part of it is to learn where they're at in really knowing about their disease.
Yeah. And then the other section of, so there are 4 subdomains for the track. And another section involves communicating with providers. So other options that the youth can choose from or tasks would be writing out their questions before coming to see the health provider, or practicing the questions before going in, or doing the 3-sentence summary, practicing with their parents or family members. So being able to communicate effectively and not come in with this 30-minute conversation that they've worked out in their head about what they're going to talk about with the provider, who generally has 15 minutes or less to see them. And we also provide different videos with examples of how to get the most out of your appointment in the time frame that you have allotted.
There's actually lots. We did a bunch of videos at our clinic that show you how to check in at the front desk, that you need identification, you need all this stuff. We show you how to bring your medicines and talk to your doctor about medicines, how to ask about different things. But there's lots of places that have these now, online videos that can break down a lot of these tasks that a lot of folks won't. There's a term that Kiana likes to use, which is social loafing.
Yes.
Everybody heard of that term?
It's from social psychology. So the general idea is taken from group or collaborative work. So if you're working in a group and someone is waiting for someone else to do the work because they want the work to be, it's an important task that they know that it'll get done. If they don't do it, it'll get done because they know that somebody else is going to pick up the slack. So in parenting, you can have this idea of helicopter parenting, but for the adolescent, it becomes the adolescent knows how to do a specific task, but chooses not to do it because it's going to get done by someone else. And I'm now working on 2 papers supporting that notion, which is really interesting. I think it's really cool because we see ways in which parents can learn to let go, but the same for providers in terms of allowing the youth more autonomy, because when youth receive autonomy or when they're allowed to take more ownership of their own health, they also become more competent in doing so, and it increases the likelihood that they'll participate in similar tasks later on.
I mean,
so they grow in competence.
Most youth are very smart about doing as little as possible. I mean, I know I am.
Adults do too, yeah.
And if my wife doesn't say take out the garbage, I'm not going to volunteer to take out the garbage. But anyway, even though I know it's my job to take out. What?
I was going to comment that it happens every day in my house.
That's right. So, but you think about the parents' side too. If you have and I remember a conversation. I had a young man who had mild cognitive impairment and seizure disorder. So we started talking about, well, who's going to take responsibility for making sure he takes his medicine? For that mother to let go of that responsibility and let that young person take responsibility for it and back away was very risky and it was really hard for her. So these are not necessarily easy things to learn. Anyway, there's lots of educational materials that we can draw from, that we can put in the clinic, that we can put in people's hands that are public domain. Yeah, I'll do it quick. We got like 3 minutes. So we'll skip that. I'm going to skip a few of these things. I just want to mention that when we're doing transition, there's a lot of milestones that happen that have to do with if you're on SSI, your insurance, if you have special educational needs in the education system that we can be aware of and help prepare families for. Now, I just want to quickly mention that we just signed a contract with Chatez, which is this online tool for all kinds of questionnaires. And so a lot of our developmental questionnaires for younger children are going to go on there, but we're putting basically the track into that, and we're working with them on these goal statements to develop prompts. So if you see a youth and they filled out this track, there'll be some prompts for you to figure out how to talk to them, to set goals for, to improve their independence.
Yeah, and we're also forming a youth advisory committee as well with youth from the region to help inform how we will do healthcare transition here in the region. That will aim to just further help youth. This is all based on healthy youth development.
I think we should stop there. So there's a few more steps in this and the handoff and everything, but we're going to just this is one more thing. Transition is not synonymous with transfer. In other words, just sending them to the adult provider. We need to do a better job of that. A lot of that is documenting well what their health issues are and what their medicines are and what their emergency issues are, so that when you do transfer them, say, to our adult medicine colleague, they can receive that information and pick up the care. And I'm going to jump to this one, which is our last one, and ask, thank you, that's our last slide, and ask if there's any questions.
Next one.
Oops, this is our last slide. Any questions? Yes, Gayatri.
Thank you for a wonderful talk, an eye-opening talk. My question is, it sounds like in the transitions clinic, healthcare transitions clinic that you worked in, you mostly concentrated on the very sick, like the kids with chronic diseases with lots of problems. And I love the track questionnaire. I think it's great and really should be used on everybody, not just somebody with chronic problems. Is that how it's meant to be used?
Yeah, I think every youth should learn to take more responsibility. As those of us that are parents and we've taken our teenagers into the doctor, we really want the doctor to talk to them independently. We want them to be able to give a good health history. All these things they'll need when they go off to college or leave home. So yes, I think it's something that we could institute, and it has been instituted across. There is true that because of the needs of the chronically ill adolescent, making sure that they are adherent with their care, we have focused on that. And some of these primary care clinics do primarily take referrals of chronically ill adolescents. But no, it's absolutely applicable across.
The transition clinic could be the chronically ill, but I think the questionnaire should
Yes.
be applicable to all adolescents kind of going through that transition phase.
Yes.
And then two, I just got a brief look at the questionnaire. Why are you taking out the ones at the bottom that is sort of the self-care management ones?
Most of it has to do with the psychometric properties of it. We like the questions. They just don't score well.
Yes.
They're not reliable when you ask them again. They're a little bit, they were not well understood, even though on the face they look like, learning to use your neighborhood resources like the grocery store, that's important too to transition.
Right, and I think in thinking of as pediatricians, we're always about prevention. So even for normal, healthy young adults, adolescents, kind of preventing later illness or disease, keeping them on the healthy track would be important. So could you reformat those questions to say, how are you following a healthy lifestyle?
Well, actually, we recently surveyed adolescents in the region, and they completed the track, and these were youth with and without special health care needs. So around 23% of those who took the survey had chronic conditions of some sort. But the psychometrics of it, so the track as it is, can be used with healthy populations. And recently, maybe within the last 3 years, a lot of research has come out that talks about young adults not having that preventative health. So a lot of them not seeing the provider as often as they need to. Right. And then even not knowing the basics in terms of navigating the healthcare system, so making appointments and getting prescriptions. I presented a couple talks at the Arthritis Foundation conference this summer, and I surveyed young adults and adolescents on health care transition. And the last session I did was for young adults, and it went up to age 26. And the mean age for the young adults there was 24. And out of this group, nobody said that they were filling their own prescriptions and going to the healthcare provider by themselves. And more than 75% said that their parents still did this task for them, which is alarming.
I mean, even if you're not on prescriptions, I think you should say, are you seeing a healthcare provider regularly? I think that, would help.
Oh, yeah.
Because they transition from healthy 18-year-olds to fairly, very healthy 24-year-olds to 35-year-olds with diabetes.
Right.
Because they haven't seen anyone,
right.
Have become obese or whatever
Yes.
else.
No, I completely agree.
So.
And we are trying to develop a module that gets into more of those
Life track.
Called the life track, we're calling it, but life skills like educational goals, basic skills like going to the grocery store and managing transportation. So we're actually working on that questionnaire to add to this that would, I think, be relevant for any parent. They want their child to become independent in all these areas. So, but yeah, good question. Anybody else?
Any tips for the adolescent parents?
Give away the children.
I'd say let go a little bit. So I've been dealing with this idea of how to teach people to let go, and not necessarily just parents, but also providers, and not just those who are treating youth with chronic conditions. But there's a way to teach. It's called scaffolding. So you're teaching a skill or a skill set, whether it be how to balance a checkbook, or reading a register, or something of that nature, to calling a prescription and doing refills. And but so it's how do you pull back instead of doing everything, and it's just a gradual process. So instead of like the parent doing making all the appointments or talking to the provider about, like, if some issue came up for the patient, allowing the patient to actually call the healthcare provider and say, hey, I'm having a problem with this. And then they can further explain that. And that kind of leads into a more competent stage of being able to talk to the doctor alone when they're actually there in the office.
But also just for parents generally, I think part of it is tolerating failure. Teaching someone to ride a bike, you don't ride it for them.
Supported failure. You
support them and they're going to fall down. And supportive failure, so that say this mom who had a child with epilepsy, we had to have some backup safeties to make sure that he did get the medicine, because we didn't want him to have a seizure, but we wanted to make him try it on his own and do as much as possible on his own. So it's kind of like a supported independence until you can withdraw the support completely.
And that's what scaffolding is.
It's hard though as a parent. It's easy to talk about like cutting down marijuana use when it's a patient. When it's your son or daughter, it's a little different story. Not that my daughter ever smoked marijuana. I don't want to say that. Okay, thank you very much.